Okay,
Ready
you're
to
on.
go? Thank you
Yes,
very
we're
much.
ready.
Good evening, everyone. I'm Mike Weimer. I'm president and CEO of the Marfan Foundation. As you might imagine, this is a very fluid time for the foundation, to say the least. Changes are literally happening hour by hour, and we're doing our best to stay on top of the situation with an eye really to protecting and also informing our community. To date, we have not canceled any events across the foundation, but we do have a number of postponements. All have been done in consultation with volunteers in the various communities. If you would like to see what has been updated with new dates, you can go to marfan.org, www, and you'll be able to see those postings on a regular basis. Fortunately, with a largely virtual organization and great operating systems, we are able to fully operate the foundation virtually should it become necessary. Meanwhile, we also have implemented stringent virus protection mechanisms in Port Washington, where our office is. But regardless of the challenges in the weeks ahead, I can assure you we will be here for you, and we will remain fully operational throughout the period. We do plan to, we've had a lot of questions about the annual conference, so we do plan to launch the annual conference site next week. It will have a generous cancellation policy, as it always does, and we are cautiously optimistic that we will proceed as planned. The good news is the vast number of registrations usually happen in the past, in the kind of the 4 to 6 weeks leading up to conference. You know, so you still have time to plan and join us in Boston, even if you wait a little while. But again, there is a generous cancellation policy. One thing we can promise you, we have a terrific program you'll see next week for the Boston Annual Conference, thanks to Dr. Lackrow and the many people that are involved day in, day out on conference. So quick update on that. It's also, you know, this is a bit of a difficult time. I think we would all agree to that, but it's also a wonderful time to be a volunteer or community member of the Marfan Foundation. We are small, but we're also mighty in our own way. As you know, we have an amazing community. We have very little bureaucracy. We're very nimble. And most importantly, our community is first and foremost in our mind on a day-to-day basis. Regardless of what happens, what we face in the days and weeks ahead, great organizations shine during these times, and I can promise you that we will continue to shine. With that brief introduction, don't hesitate to reach out to anybody at the foundation should you have questions or desire information. You'll hear more about Jan Lynch, who directs our resource center later on. But now the evening is really about you. We have the finest professional advisory board in the business, any organization that I know or have ever been part of. And you will spend the evening with 3 of our extraordinary physicians, along with our Chief Science Officer, Joe Grima. Enjoy the evening, stay well. Joe, it's all yours.
Thanks, Michael. I want to first thank all the members of the Professional Advisory Board working really hard over the last 2 days to put a statement together to really try to understand who within our community is at higher risk, because that is the question we've been getting most often. And we've worked really hard to do that, because there is not one blanket statement that covers all of the disorders, because there is so much variability within each one's individual phenotypic expression. And so, sorry. And so I'm really glad that we put this statement out. We are going to go over the statement with you and go over some of the specific questions that you had around some of the other symptoms that we've gotten over, I don't know, maybe 600, 700 questions that we've gone through and pulled out some very good topics that we think will be great to ask on this, and we'll be asking several other questions later that Eileen Michelli, our Chief Program Officer, will moderate afterwards. So I want to introduce our panelists. We have Enid Neptune from Johns Hopkins, one of the experts in pulmonology. We have Juan Bowen from the Mayo Clinic, who is the director of the Marfan clinic there. He's specialist in internal medicine. And Shaine Morris from Texas Children's Hospital, who is a pediatric cardiologist. So let's go to the first slide, and we'll ask Enid to take over this slide because we want to see who is at risk and those that have significant lung disease. And so Enid.
Hello, everyone. And we are tasked to give you as much information as you could possibly want tonight. And the first issue is how do we create these designations of who is at high risk? I feel the best way to look at this is the realization that about 20% of persons who are infected with this virus will develop such serious disease that they will require hospitalization. And so when you look at that 20% number, you should recognize that those are not exclusively people who are older. They're disproportionately older, but not exclusively older. So what is represented in that 20% are people who have underlying disorders that makes them less able to tolerate a more severe manifestation of this viral infection. And so we constructed this list of lung disorders that are seen among our Marfan, Loeys-Dietz, and VEDS patients that should place them in what's considered a higher risk group. And this includes restrictive lung disease, because as I always say, when you can't take a deep breath, that means you don't have as much of a reserve as someone who can take a deep breath. And restriction in Marfan syndrome is often attributable to chest wall deformities or scoliosis or respiratory muscle weakness. And we see all of those in Marfan syndrome, and they are not uncommon. The other disorders that place our patients at higher risk include emphysema. And this is especially true when you have blebs and when you have a history of pneumothoraces that are recurrent. And so a single pneumothorax does not mean that you have underlying lung disease. But if you have recurrent or multiple pneumothoraces, that is a very strong indicator that your lung tissue is not normal and that it is somewhat vulnerable. Obviously, when you have significant asthma, that requires medications and sometimes antibiotics and inhaler treatments, that is a risk factor, again, because there's less reserve. If you have a diagnosis of chronic obstructive pulmonary disease with or without a history of smoking, that places one at higher risk. And if you have respiratory insufficiency of any kind, and what I mean by that is if you require some respiratory support, be it oxygen, be it frequent treatment for pneumonias, or if you are under the care of a lung specialist, then that also should place you in the high risk group. So I hope it's clear that the idea is that an underlying disorder of the lungs that will compromise your ability to bounce back or respond sufficiently to a serious viral infection is why we've designated these groups as high risk. And what does that mean in terms of management of a possible viral infection? Well, it means that you have to assume a protective posture. And the first person you protect is yourself. The second group that you protect is your family. And the third group that you protect is your community. And when it comes to protecting yourself, that means monitoring your status. If you have a cold that is persistent with a high fever, then you need to contact your healthcare providers. They need to know so that they can put you in a queue to either be tested or to tell you to monitor yourself for further symptoms in order to be tested. But the idea of being in a high-risk group means that you reach out to your healthcare provider early. when you have these symptoms. The second issue is that you want to minimize your potential exposure to persons who might in fact have the viral infection. And that means, of course, knowing your community, but also not placing yourself in high risk situations, such as with crowds or in groups where you're exposed to the public and you cannot control the people that you encounter. And the last thing is being especially careful in terms of personal hygiene. You have to have your bottles of Purell, and you have to have your antibacterial wipes, and you carry them around with you, and you wipe off all the surfaces. And if you need to set an alarm on your phone so that it reminds you to use these approaches every hour, then you should do that. But the main thing to think about is that you assume a protective posture of yourself, your loved ones, and your community.
Okay, I think maybe we can go to Juan to start talking.
Okay,
about...
can you hear me okay?
Yes, yes, Dr.
And
Bowen.
can you see me?
We can't see you.
Okay. Now, I'm not sure what to do about that.
On the bottom left of the screen, there's a little video camera. You can click on it.
And if not, that's okay. You can just go through the slides.
Okay.
It's okay. It's okay.
You can just start.
We don't want to hold it up.
Okay. I think something is covering it up.
That's okay. Don't worry about it.
It says Zoom is unable to detect a camera, so for whatever reason, it doesn't detect it. Okay, so my slide says who is at high risk. Can you hear me okay?
Yes, that's it. You're
Okay.
who was at high risk? That's you.
Yeah, so anyone who with a genetic aortic condition is a higher risk if they have basically significant heart problems or significant lung problems. So people with significant leaky valves, and by that I mean severe enough that it's causing a symptom or requiring a medication. Or if a heart failure is a problem, that would clearly be an indicator of risk. And also, not everybody who's got a ventricular dysfunction, has obvious heart failure. But if you have ventricular dysfunction and it's requiring you to take medication, then that would be an indicator of increased risk. And people with high blood pressure, particularly if it's not completely controlled, and particularly if there are medications are required to control it. So those would be high-risk people.
Next
And
slide.
I think we're ready for the next slide. Yeah. Now, also, some people in our community have other conditions that might make them even higher risk. So that might be if you're underweight and anybody who's been ill and malnourished. Some people are on immunosuppressants, and a common reason for that might be inflammatory bowel disease, but there are other reasons. Some people have skin conditions or multiple sclerosis, something else that requires the use of an immunosuppressant. And then finally, anybody who's requiring steroids. So some older patients might have, polymyalgia rheumatica or another condition like that, or people with difficult asthma might require steroids or immunosuppressive drugs. So all those categories would be considered at increased risk. And then, now what if you clearly have, a problem and you have a dilated aorta, but you really don't have any of those other complications? And many, many people with Marfan syndrome or a related disorder might have a moderately dilated aorta, but otherwise they're really okay. So in general, I think, and I'd be interested to see what the others say, but if you have a stable condition, let's say you haven't had operation yet, and that's all that's wrong with you, you probably are not at very much increased risk. Now, if you've had heart surgery, and let's say that it's been fairly recent in the recent months, I would say that would be something that would place you at increased risk. But if it's been quite a while, 6 months or longer, then I would think the risk would not be much above the baseline for the population. Aneurysms beyond the aorta, this would be, if there are stable and small or moderate-sized aneurysms, I would think that would be in the same category. We don't have firm data about that, but those are usually would not be considered conditions that would place you at very high risk. And then I think, all of us are individuals, and your primary care doctor would have, a little better ability to determine your risk status. It's always a good idea to discuss it with your primary care doctor. And so then, what do you do? Well, I think it's always, and these are, by the way, the CDC website, as I think everybody knows, is an excellent source of information. Here in Minnesota, we have, the Minnesota Department of Health, and of course, internally at Mayo, we have our own internal Mayo website. But all of these are reminding everyone that basic principles to protect us all from respiratory infections are important here. So people need to have influenza vaccines, pneumonia vaccines up to date. And then look at the protective guidelines that the CDC produces for people with chronic illness. We are available, of course, for questions and help, but there's nothing like your primary care doctor who can see you in the office, examine you, and assess your own individual risk, and also get you the prompt testing and evaluation. You might need a chest x-ray, you might need blood tests, and some people will need immediate treatment.
Thank you, Juan. I think the next slide goes to Shaine.
Sure. I'm just going to make another comment based on the vaccines. One thing just to make clear, can you guys see me or no?
Yeah.
Yes.
Okay. I can't see myself. So anyway, one comment to make clear about the vaccinations. There's two kinds of pneumonia or pneumococcal vaccinations. So there is one that all children get as part of their routine vaccination series. And so a lot of kids are covered from most of the common pneumococcal bacteria, but children with chronic conditions, and I can go back to that in just a second, should get additionally the Pneumovax 23, which has additional sort of vaccinations in it. And so the reason for this is secondary infections. If someone gets a coronavirus, especially children or young adults with chronic conditions, they can get a secondary infection. So these would be people who need Pneumovax 23 are people with chronic heart failure, chronic severe dysfunction, or possibly severe mitral or tricuspid regurgitation, although that's pretty uncommon in kids, but possibly the neonatal form would be ones we would consider to get the Pneumovax 23 in childhood. Just wanted to clarify that. And everyone should get flu. Great. So let's talk about treatment a little bit. So basically, you want to get treatment as soon as possible if you think you have symptoms. Now, there's no cure for coronavirus right now. As we know, most viruses, there's not a treatment for. There are treatments for like influenza. There's something like Tamiflu, which can shorten the duration of the flu. And people all over the world are trying different antivirals to see if certain antivirals shorten the course, but nothing is there so far. So the care for coronavirus right now is supportive care. And so this is staying well hydrated, staying rested, if you have to go to a hospital, taking care of any oxygen requirement, et cetera, and dealing with secondary infections. So the secondary infection most commonly is pneumonia. Now, the most common antibiotic given for pneumonia for adults is fluoroquinolones, most commonly ciprofloxacin. And so as most of you guys probably heard either at conference or on the website or from your primary care provider or your cardiologist, these have recently been shown to increase the risk of aortic dissection in the general population. So there is guidance to avoid these fluoroquinolones in people with Marfan syndrome. And so there's lots and lots of other antibiotics that are good antibiotics for pneumonia. So these should be taken instead. So the list of antibiotics that are in this class to avoid fluoroquinolones are Avelox, Cipro, Bactid, Levaquin, and ofloxacin. And Cipro, Levaquin, and ofloxacin are the most common ones. So now other treatments, so the symptoms of coronavirus are very similar to the common cold. In fact, the common cold is a different type of coronavirus. And so you might take cold medicines. And so cold medicines, there's different kinds of cold medicines. Common cold medicines are antihistamines. This is like Benadryl, Allegra, Zyrtec, Claritin. Those in general are okay. Another kind of common medicine, cold medicines, are a group of medicines called decongestants. And these are medicines that sort of dry up.
You forgot how to turn the phone off on this thing.
Yeah, does someone need to mute? See, should I pause for a second? I think someone's not on mute.
I think Juan has to mute. Hold on one second. I
Okay.
think he's trying to get somebody to mute it. Juan, you have to mute your, look on the picture on the right, on the top right, you'll see a button that says mute on your picture. Very good. Perfect. Thank you. Thank you.
Great.
Yes.
All right. So, so the decongestants are basically stimulant medicines. So stimulants, sort of, you can imagine sort of like coffee is a stimulant, but these are much more powerful. And we do want to avoid these for almost all of our patients. They can speed up your heart rate, they can speed up your blood pressure, sometimes make you feel a little better, but they can certainly have negative side effects in anyone who has chronic cardiovascular conditions. So for cold medicines, we do recommend avoiding anything as a decongestant. Now, as a help, most of the decongestants are listed here: pseudoephedrine, ephedrine, phenylephrine, nifazoline, and oxymetallazine. Most of them now you have to get them directly from the pharmacist. You can't buy them in the aisles because they're actually used, they can be used to make methamphetamine. So you usually have to actually get them from a pharmacist, but not with a prescription. And so anything that's a D, like Claritin D, Zyrtec D, Allegra D, those all have a decongestant, and you want to avoid that. Other cold medicines might be ibuprofen or Tylenol. And so those generally, you need to talk to your doctor specifically if you can take those, but in general, if you're not, those are okay in most patients with Marfan syndrome, VEDS, and Loeys-Dietz. Oh, it's here, yeah. This one's still mine, right?
Mm-hmm.
Great. So, so taking a pain reliever like acetaminophen, which is Tylenol, that's really good for fever, sore throat, headache, body aches, basically for pain or for fever. Tylenol is a great option. For some patients can take ibuprofen, some patients can't. That also is good for fever and pain. For nasal congestion, so this is what some people take decongestants for, but we definitely advise against it. A saline nasal spray is really safe and effective. You can get them over the counter anywhere. It just sort of you spray into your nose. It can help moisturize your nasal passages, decrease inflammation and swelling. They can really help a lot. And then if you have a sore throat, apart from taking a pain reliever like Tylenol, you can gargle with warm salt water. You can drink lemon juice and even honey. In fact, for sore throat or for sore throat and cough for children, honey has been shown to be for cough just as effective as over-the-counter cough suppressants. So again, more supportive care, and this is everything we need to do. Drinking plenty of fluid allows your body to mount a faster immune response. You can take water, juice, tea, soup, anything to keep you well hydrated and keep the mucus. If you get really dehydrated, the mucus can get really sticky, and then that can cause make a harder time breathing because that sticky mucus gets caught in your airways. You can also increase humidity at your house. So this is using a humidifier. We recommend cold mist humidifiers to decrease mold, or a vaporizer. And that can also, all of these, just the same way that having a hot shower makes you feel better, having a humidifier around and bring fluid helps to decrease these mucus symptoms. And of course, getting plenty of rest to let your body help heal itself.
All right, thank you, Shaine. So now we'll go to a couple of the questions that we received in advance. And if you have additional questions, please remember to put them into the Q&A box. So let me go to Enid first. Enid, you had said that pectus and scoliosis can cause restrictive lung disease in certain instances, but if you've had that corrected, do you still have the restrictive lung disease?
Yeah, that's a great question. What we know for sure is that most of the surgical, as well as the semi-invasive interventions that are used to treat pectus and to treat scoliosis, can slow the decline kind of in the lung dysfunction, but they typically do not restore kind of the normal lung or breathing capacity. So if one of the reasons that a person is undergoing these procedures is because they have existing restrictive lung disease, the more likely than not, they will not regain kind of lung function because of the intervention. So I would say that if you have pectus or scoliosis, and there's already been some corrective procedure, that you likely have some measure of restriction that will persist. The severity of the restriction one cannot predict. And I think it's safer to place oneself into the high risk group for coronavirus because there's likely a limited degree of lung reserve in the event that there is a viral pneumonia or, as Shaine was mentioning, a superinfection with a bacterial pneumonia that follows the viral infection.
Okay, thanks, Enid. So if you know that you have bronchial ectasis, does that put you at a higher risk?
Yes, because the diagnosis of bronchiectasis, which is effectively kind of a widening of your airways in your lungs and a chronic level of inflammation such that there is low-grade infection that often needs to be treated with periodic antibiotics. So that setting of known infection, known inflammation makes the added insult of a viral infection even more consequential. So if you have a diagnosis of bronchiectasis, you most certainly are in a higher risk group with respect to COVID.
Okay, thank you. So you also talked about having several, if you had several pneumothoraxes, is there a difference whether you've had several of them and you had pleurodesis and not pleurodesis?
Not really, because the experience of having multiple pneumothoraces effectively tells us that there is abnormal lung tissue. And the interventions are, the pleurodesis is probably not going to improve the lung tissue. What it does, it reduces the risk of the lung fully collapsing with the next episode of pneumothorax. And it may reduce the risk of having another pneumothorax, although that's less persuasive than just reducing the severity of the next event.
Uh-huh.
So if you have recurrent pneumothoraces, you can very well assume that you have underlying chronic lung disease.
Uh-huh.
I'll get my voice back eventually.
Are your lungs okay?
All right, one last question for you, Enid. You know, it is the time for spring break and everybody seems to have travel plans. And there were many questions about, should I travel? Should I travel on planes? Is it safe? What would your response be to that?
I think everyone has to make choices about essential and non-essential travel. And these are very difficult choices because they seem unfair. But I would say that all non-essential travel should be set aside because there is a measurable risk with any type of air travel. I'm going to get water.
Okay.
So I would think spring break travel falls into the non-essential kind of category.
All right. Okay. Thanks. Thanks, Enid. Okay, Juan, I have a number of questions for you. Can you unmute?
Can you hear me?
Yep.
Okay, good.
So there were some questions about several people had, in addition to Marfan, mast cell activation syndrome. And does this put them at a higher risk?
I was afraid I was going to get that one. So this is a disorder of the immune system where the mast cells degranulate and release histamine and produce urticaria or even angioedema. And it's an unusual condition, so I don't have any experience with it. So my answer, I don't think can be perhaps very authoritative, but it is an immune condition. And I would have to say that anybody with this particular condition is at increased risk.
All right, thank you. Do you have any words of wisdom for people who are currently pregnant and whether they would be at higher risk?
Yeah, this came up as a question earlier today, just in practice. And there's really almost no information about this. There just haven't been enough cases and enough high quality information. I think a little bit like some of the other questions. Yes, I think pregnancy is a state of vulnerability and potential increased risk. So I would have to say that people who are pregnant should follow all the regular precautions, but really maybe be extra sure that they're following them well and avoiding non-essential travel and doing all the things that the CDC recommends, because I think they probably are in a state of extra vulnerability.
Mm-hmm, mm-hmm. Okay, thank you. Is there any cautions they have to take if they get an antiviral with the common medications that are prescribed for patients with Marfan syndrome and these other genetic aortic conditions?
Well, yeah, maybe some of the others can offer an opinion here. Not to my knowledge, but there may be something that I'm unaware of, but at least as far as my knowledge would be no. It is okay to take antiviral medications.
Shaine?
I agree.
I agree also.
Okay. Are there any interactions that are going on with the ACE inhibitors and ARBs and the coronavirus?
Well, there are some hypothetical things, and so again, my other two partners may know more, but what I know is that the coronavirus, those little knobs on the surface of the coronavirus, they connect to the angiotensin II receptor, and that seems to be one of the ways that they attach to the cells in the body. So, of course, our favorite medication, losartan, blocks that particular receptor. So it's an intriguing idea whether the people who take losartan may have some protection against this virus because that is the attachment point. But that would be a very, the old, the former pandemic virus, the SARS virus, had the same type of mechanism. But to my knowledge, there are no clinical studies about this. It's just an interesting hypothesis. Do either of you two know any different?
No, I think that poses a hypothesis, but on the alternative side, in China, people with hypertension have had significantly higher risk. And why hypertension puts you at higher risk of death with coronavirus is really unclear. So there's a question whether that's somehow mediated by this angiotensin receptor issue.
Yeah, I think there's a lot of speculation that's attached to it, but I don't think there's any persuasive clinical evidence that it's a therapeutic intervention of choice. So,
all right, thank you. There are sometimes some myths that go around, or well, I call them myths, that when you have Marfan syndrome, that you have a lower immunity. Can you speak to that?
Well, no, to my knowledge, no. Now, there are some exceptions. For example, Loeys-Dietz syndrome, because the TGF-beta pathway is such an important part of the development of the immune system. In that particular case, there are immune-related phenomena that occur in Loeys-Dietz syndrome, such as eosinophilic esophagitis and also phenomena like increased tendency towards allergy. But at least to my knowledge, that's not a major issue in the Marfan syndrome. There may be individuals, but as a characteristic of Marfan syndrome, I don't believe so.
Mhm. So you would say that then those that have, for Loeys-Dietz, they may be more, they may have a lower immune system if they have those GI issues and those allergy issues.
At least in theory, they would, and I would have more concern about them.
Okay, Shaine?
I would totally agree. I would say the subset that have those issues might be at increased risk, but I think that's I think it's pretty uncommon to see significant immunocompromisation. You know, we see people who undergo surgery all the time and they recover in a pretty typical way. Even patients with pretty severe Loeys-Dietz, they're not getting a lot of secondary infections. They're not getting a lot of complications. So theoretically, yes, with the asthma and with eosinophilic esophagitis.
The only caveat I would add, Joe, is that if the allergies or the asthma is so severe that they're on kind of inhaled steroids or systemic steroids, those interventions would actually make them somewhat immunocompromised. Right. So it could be the medication rather than the underlying disease that could confer the risk status.
Mm-hmm, mm-hmm. Okay, great, thank you. Should patients be concerned that there might be possible medication shortages?
I would say yes. There is a situation in the United States where many of our medications are manufactured abroad. And we have seen in the last couple of years, of course, with losartan, but with other medications too, periodically there will be problems with manufacturers, and an important medication may be in shorter supply because there may be a limited number of manufacturers. So unfortunately, nationally, we do have some vulnerability. Now, it hasn't been a huge issue for most people for most of the medications that they take, but I think there is some risk of problems in the pipeline of medications.
Mm-hmm. Mm-hmm.
I was just going to comment on a slightly different vein of that. I think Dr. Bowen's talking about the routine medications, and I 100% agree. Another thing to address is that part of the efforts, I'm sure you guys have seen in the last 2 days, all over the United States, efforts have been really stepped up to stop congregations, to stop traveling, to stop keeping distance from people. And a lot of that is to slow the spread. And a lot of this is utilization of hospital beds, medications, healthcare providers, time. I don't know if you guys, this is the graphic I was talking about, but in places where they haven't sort of intervened quickly, when the virus spreads really rapidly and you have really rapid need of healthcare services and medications and everything. And so Italy is really struggling with this right now. And so a lot of these efforts that sometimes may seem overboards, closing schools, stopping travel, is also to slow the spread so that there are more resources like medications, like hospital beds. And so that's in direct response to this for like secondary infections, et cetera.
Yeah, and the question is, can our healthcare system handle X number of cases? And the answer is, it can handle them a lot better if they're spread out over 3 or 4 months than if they all occur in just a few weeks.
Mm-hmm. All right, thank you. There were some questions about people, have already surgeries scheduled and, their upcoming tests at different hospitals. Should they be concerned or postpone these visits?
Well, my answer to that would be it depends on local conditions. So if you're in a very low risk area and the procedure that is anticipated for you is something that will be short and won't require a prolonged recovery, I think that's one issue. But if you're going in for an elective operation that's a little more involved and in an area where the health resources are more stretched, then if it's elective, I would postpone it.
Shaine? And I was just in the operating room today helping with imaging. So we are in Houston, we don't have a ton of cases. We have a fair bit, but for 8 million people, we don't. So I think exactly right. In cities where it's not super high, we're proceeding with all cases that seem necessary. We haven't really slowed down operations and haven't been recommending that yet, but I agree if you're in a city, like if you're in Washington or somewhere else where there are a lot more limited resources, for sure, I would delay.
Mhm. Okay, thank you. Are there any additional risk for people with dysautonomia?
Not to my knowledge. Juan?
It depends on how severe, I guess. You know, for example, in younger people, I think that dysautonomia would more likely take the form of, you know, postural tachycardia and postural hypotension. So some risk there of getting volume depleted. But in the older people, the autonomic disorders that we tend to see are neurodegenerative disorders like Parkinson's disease with a lot of autonomic instability. So, you know, it kind of depends, but I think for the older people, yes, I think I can see a lot more risk. For the younger people, probably not too much more.
Okay, all right, thank you. How about people that have had an ostomy?
I don't see any extra risk there.
Shaine, no?
Agreed.
Okay. All right. So I have some questions for Dr. Morris. For those that have LDS and VEDS that have tortuous arteries and fragile arteries, does the virus or the symptoms such as the coughing that's associated with the coronavirus or any flu increase their risk about the stability of their arteries?
I don't think so. You know, the tortuous arteries we see a lot in Loeys-Dietz and Marfan syndrome and a little bit in VEDS, but that's more just a sign that they have a more aggressive form of the genetic condition. But the force that you cough with is not nearly the force it takes to dissect or rupture a vessel. So I don't think that that increases your risk, other than the fact that people who have more tortuosity tend to have a more severe form of the disease. But I think it still comes back to, do you have heart failure? Do you have lung problems? Do you have regurgitant valves? But just having tortuous arteries I do not think alone would increase your risk with the coronavirus.
Okay, great.
I just would want to weigh in on the subset of VEDS patients who have lung hemorrhage. I think for those patients, there is a concern about kind of refractory cough. And I think those patients definitely need to contact their healthcare provider if they're developing symptoms that seem to be an upper respiratory infection, and especially if it's associated with fever. I am very aggressive with my VEDS patients with lung hemorrhage when they have any type of respiratory infection, because although you think that a cough is pretty well tolerated, if you have kind of very fragile vessels in your lungs, that it's not kind of without, it's not outside the realm of possibility that very forceful coughing can trigger a serious bleeding episode.
Okay, thank you. Shaine, if there are children that are immunocompromised, should they be pulled from school?
Well, I think it depends what immunocompromised means, because again, we talked about most of our population, unless they're on chronic steroids, we wouldn't really classify them as immunocompromised. What I've been telling most of my families with schools is that, you know, to go by the school guidelines, we don't know how long this is going to last. Really pulling your kids out of school, if the schools haven't closed, I think is a pretty extreme measure. Now in Houston, a bunch of schools have just closed. So I think it's region by region's risk, but I would be very reluctant universally to say to pull out of schools if the school hasn't had an immediate risk, if they haven't had cases, if your community is not as well affected.
Okay, thank you. I think that's all I had on these set of questions. Eileen, do you want to go into the Q&A box and see what questions have come up from there?
I absolutely will. Let me put my video on. That's only fair. Okay, I'm sorry. My phone is dying after the day today. So can you hear me now, guys?
Yes.
Can everybody hear me? Okay, great. So, God, thank you so much, great information. And we had, as Joe said, we had so many questions submitted, and there are still people putting questions in the chat box. So if you want to throw them into the Q&A box, that will help us answer them now or even afterwards. So I will go in there and let's see what we have here. Shaine, Erin wants to know, is her child at higher risk considering they have a higher Z-score and is medicated?
So no, we wouldn't, if a Z-score, I assume they're talking about the aortic root or ascending aortic Z-score. If they're talking about that, having a larger aorta, we don't think puts you at increased risk of morbidity from coronavirus. Now, if you're talking about, occasionally we give Z-scores out for the size of the ventricles, like the left ventricle or right ventricle. And in that case, if you have ventricular dilation, that might, you would already know, but that might be a sign of heart failure or cardiomyopathy or valvular regurgitation. And in that sense, if that's a Z-score, you might be at higher risk. But most of the time when we talk about Z-scores and medication, we're talking, especially in children, we're talking about aortic root Z-scores, and we don't think that increases your risk.
Okay. Carolyn is asking a question that's not really about the virus. She's asking about getting pregnant. So Carolyn, I just want to let you know that there is a webinar coming up on pregnancy and Marfan. So look at our website and you'll be able to get all the information you need there. I just didn't want to ignore that because we do have that coming up. This question has come up a lot, and it's kind of a mixed thing. So if somebody in the family is immunocompromised or needs to stay home and away from other people, what about the rest of the family? I mean, can they go about their life and then come back in? And what about the risk of them bringing virus into the house? And how do families handle that? What do you recommend?
Well, my own, I'm not sure that we may not all agree completely on this, but this is why it's nice to have testing. So this is one disadvantage that we've had in not having widespread testing. But if testing is available and you know what the problem is, for example, if it's influenza A, then you follow the appropriate guidelines for influenza A. And I think a risk assessment is important. So if you're in a place where there really is almost no chance that you could have coronavirus, an isolated rural place or somewhere where there hasn't been, any concern at all, people are going to continue to get viral respiratory infections. So I think that would be very low risk. But if you're, for example, the city I'm in right now, we thought was very low risk a week ago, and now we've had several cases. So it does change day by day, unfortunately, in some parts of the country. But in general, I think today, as more testing kits are being deployed in communities, the ideal situation would be to get tested and know what you have, and then you'll know what to do.
Great, thank you. Here's a question for Enid. Does mupirocin ointment in your sinuses prevent transmission of the virus into your nose?
What is the medication again?
I'm sure I botched how you say it. It's M-U-P-I-R-O-C-I-N. Mupirocin.
Oh, I see.
Was I close?
No, there are a lot of old wives' tales that are circulating in social media about strategies to kill the virus, prevent it from kind of infecting your lungs. But no, that is not an effective way to get rid of the virus. I think the best posture until we have a vaccine or until we have a definitive treatment, or as Shaine mentioned, some antiviral that will shorten the course of the infection, is really to protect yourself and to protect your family. And so I would add to what Juan said, that if you have someone who has an underlying health issue who lives in your home, then you have to be especially protective of that person. And that means that you want to limit your exposure to people, to the public, to large crowds. You want to kind of use very kind of established personal hygiene practices that we know will work, because there's, even though you may not develop the severe consequences of the infection, if you transmit the infection to the immunocompromised person in your home or the person who has an underlying cardiopulmonary health issue, they could certainly develop the more severe complication and wind up being hospitalized. So I would say, exercise all of the practices that we discussed, especially if you have someone in your home who has one of those kind of predisposing conditions.
Thank you, because a lot of people ask that in one way or another, so I appreciate that answer. Enid, one more for you here. What about sleep apnea? Does that put people at increased risk for the virus?
Yeah, I thought about that a great deal, and I do think that's contextual. I think if you have sleep apnea and also have a cardiovascular issue, hypertension, or a systemic kind of metabolic issue like diabetes, or one of the lung issues that we cited, then I think that would place you at higher risk. I think in isolation, I would not consider sleep apnea as kind of sufficient to place one in a high-risk group.
Okay, thank you. This is for Shaine or Juan. Does having a type B thoracic aortic dissection put you at higher risk?
I'll let Juan answer that.
Well, I can tell you my answer. So, very little information exists about health in people who have a chronic aortic dissection. But there certainly is risk if bacteria should gain access to the bloodstream. I had a patient last year who had a chronic dissection, and then unfortunately did have an illness where he had bacteria in the bloodstream, and then the chronic dissection became infected. So yes, there's more vulnerability. But however, I think for most illnesses that are respiratory illnesses, probably not a significant increase in risk. But it's when other things begin to happen and then you get these bacterial complications, I think that's where that would be a more serious problem.
Okay, thank you. There are some questions here that I know this was addressed earlier in the presentation, but people are still asking. So let's just talk about this one more time. If you've had recent surgery, to whether it was aortic surgery or somebody said they had severe leaking and heart failure, and they had surgery. They said recently. They didn't say how recently. Can you just repeat the guidelines that you said? You talked about 6 months and.
Well, that would be a sort of an educated guess, but in general, by that period of time, there's been complete healing. Suture lines are definitely healed, and there's maximal healing of just about everything. And so your body would really have kind of rebuilt itself in a very reasonable way. Before then, no, there's still healing going on. There's still an inflammatory process in the body. So, for some people, that might be 3 months or 4 months. But in general, the closer to the time of surgery, the greater the risk.
Okay, thank you very much for that. What about people with either several aneurysms or people with multiple aneurysms and dissections who might have VEDS? Again, we touched on it, and I think the challenge here is it's just not black and white, and you all, are experts in in Marfan and related conditions, and this virus is new, and there's no absolutes. But can you just talk again about who is at risk, has the cardiovascular risk, having aneurysms or small aneurysms or many aneurysms? How can we help people with that, understanding their risk?
I guess my answer would be that person, the more of these things as they begin to add up, the more careful you are so that you don't get it. Really take seriously the social isolation, all the things that Enid talked about protecting yourself, because I think you might be at increased risk. This would be someone who really doesn't want to get it.
Okay,
and Shaine,
great.
do you have more to say?
I would also add this finding that we see in many of these vascular lesions, that there is often an element of inflammation. And so it's not simply kind of a structural kind of deterioration in the aneurysm. There's often what we call inflammatory cells that are present that cause a low-grade inflammation. And we don't know what the systemic consequences of that kind of chronic inflammatory state might be. And so, whereas we can say that there are no explicit indications that persons with multiple aneurysms fall in a high-risk group, I could construct a scenario where I would say that they may well have some exposures and some susceptibility because of this issue of chronic inflammation.
And I think that's really different when you're talking about someone with VEDS with lots of peripheral aneurysms, or someone Loeys-Dietz with lots of peripheral aneurysms, versus the vast majority who have like a single large aortic root aneurysm or dilation. We think those patients are pretty low risk. But for sure, especially if you have dissections, there's going to be inherent inflammation. And if you have multiple peripheral aneurysms, I agree, Enid, then you might be at increased risk.
Thank you. Staying in the cardiovascular area, somebody writes that their daughter has mitral valve prolapse. Is that considered significant valve regurgitation, or are those different?
So prolapse is a mechanical problem with a valve where it's sort of redundant and folds on itself more than it would normally. And when you have prolapse, it can cause regurgitation, but it's not implicit. Plenty of people have mitral valve prolapse with no mitral regurgitation or mild mitral regurgitation. And in fact, that's very common. And I don't think mitral valve prolapse in the absence of mitral regurgitation or with mild mitral regurgitation would put any increased risk. Now, some patients, especially like neonatal Marfan patients or a fair number of patients with Marfan syndrome, have mitral valve prolapse that causes moderate or severe mitral regurgitation. And we do think those people are probably at increased risk, because when you have moderate or severe mitral regurgitation, your heart is working harder, your heart tends to be more dilated, you tend to have less reserve. And so we do think those patients are increased risk, but not due to the prolapse alone, but only if prolapse is associated with regurgitation.
Thank you for that. There are several questions about, what are the standard hygiene practices, or what are the starting symptoms of COVID-19? And I'm just going to hold off on those right now, because those are in some of the basic CDC materials, and we'll send those out. And I just want to make sure we get to some of the really focused Marfan, Loeys-Dietz, VEDS questions here. So just want to let people know, because I'm seeing those questions here. Let's see, a lot of people's very personal stories in here. So if we don't get to anything that's extremely specific about your situation, we'll give you the way you can get those questions answered afterwards through our help center. So we talked before about if you have surgery planned and whether it's a necessary surgery, is it elective surgery. What if you have an appointment? Let's say you're traveling to Mayo or you're traveling to Hopkins for an annual exam. Should you still go because you're getting on a plane, you're going, or you're taking public transportation? You all know how hard it is to schedule those appointments. So should people keep their appointments or try to change them and put them off?
I guess my answer would be, if you're in the high risk group where it's more risk for you to travel, and if your appointment can wait, then I think you should postpone it, and it's a completely elective issue, then do it in a month or two. That would be my answer.
And just to comment on a pediatric side, this isn't going to apply to that many patients in our community, but if the surgery you're having is to improve, like if you're having mitral valve surgery because it's trying to improve your status, it's something to really balance with your physician, because if your heart is being taxed because you have significant mitral regurgitation or because you have a lesion that's going to be better after surgery, I think you really need to talk with your physician to weigh those risks. But our community, mostly elective surgeries, planned surgeries.
Okay, great, thank you. I'm going to go back again, Juan, to this, if you've had recent surgery, and are you at high risk? So we talked about, the risk for people who have had recent surgery. Are there additional precautions they should take if they're in that group?
I think it's just good adherence to, when you look at how the virus is spread, it's droplets, and it is You know, about I was listening to an interview on the radio with a British expert, and what she was saying is 1 meter, you know, the source person will, you'll want to be 1 meter away, but you could even expand that by a little bit more. So I would say that is, these increased risk people really should take that social distancing seriously and be, you know, several feet away from others, if at all possible. That's how it's transmitted. Now, it's not that surfaces cannot transmit, they can, but the primary method is inhaled aerosol droplets that are exhaled or coughed by an infected person.
This is Dr. Neptune again. The one thing I would add to what Juan says is that you have to look at the waiting room as a potential point of exposure. And so when you're thinking about your follow-up appointments after surgery, I would talk very closely with the surgical team to find out if there are options in terms of telemedicine and other strategies so you will not have to wait kind of in the waiting room. It's become one of the areas of concern for most of us who have outpatient practices. And we haven't come up with a rather seamless way of moving people who may be at moderate risk to a different area so people are not exposed. So I would also consider that when you're arranging your follow-up visits after surgery.
Great point. This isn't really specific to these connective tissue conditions, but I think it's an important question, which I actually curious about the answer to this one too. If you contract the coronavirus, does your body build immunity to it, or can you contract it again? Or do we know?
I don't think that's known.
Yeah, too new. We're on the first go around right now, right?
No, that's not known.
And that's,
yeah, we don't know that yet.
There's more things that we don't know about this virus than what we do know. I mean, the idea that it'll burn itself out, that's also unknown. The idea that children are fully resistant, that's also something that we don't know. We don't know the basis of that or whether that will change over time. So I would have a great deal of skepticism about anything that's said with a great deal of confidence at this point, because it's a new virus.
Okay. Yeah, we just don't know everything yet. We don't know a lot yet. So there's a lot of talk about social distancing, and you see schools being closed 3 weeks, 4 weeks, a whole semester, and everything else that's closing down. Do you have any idea, you know, social distancing, is it should be 2 weeks, 6 weeks? I guess we just want to know your opinions. And is it different from, and I guess the other thing is it different for people with Marfan and Loeys-Dietz and VEDS and these aortic conditions?
My answer to that would be it's local. You know, these communities are so variable. And I'm sure we'll see waves that come and peak earlier in a certain community, and then it'll happen later in another one. So it would be a local question, I think.
Okay. Okay, here's some of the same questions are being repeated. Okay, somebody's saying they have not had the pneumonia vaccine yet. If it is given now, how long before the protective effect starts taking place?
Well, for adults, it would be on the order of weeks, maybe 4 weeks or so.
Is it different for children?
We usually say
4 weeks. Okay.
But that's why you should get it now, because we think this is going to continue to go, and it would be a second, you know, this is to prevent a secondary infection. So first you would get a viral infection followed by a bacterial infection. So. Okay.
Do Loeys-Dietz patients have similar lung fragility as VEDS patients, and does it result in restrictive lung disease? Enid, that one would be for you.
Oh yeah. What we've seen and this is based on a subset of Loeys-Dietz patients, is that we have seen those with obstructive lung disease and emphysema, even though there's no substantial smoking history. We've also seen some changes in their lung vessels, and that's actually a new finding that we're putting together for publication. I think there's every evidence that there is underlying lung fragility, and I hate to bring the mouse models up in a webinar like this, but we've seen very clearly that the mouse models that have the same mutations as patients have in the TBR1 and 2, that they have some degree of emphysematous changes.
Okay, thank you. Scott is asking about the antibiotic class that increases the risk of dissection, and I'll just say that's the fluoroquinolones. And we do have a statement on that on our website. So you can go look for that, Scott. We have that all written out. Some questions here that are general, and we totally want your questions that are general Marfan questions or general Loeys-Dietz questions or general VEDS questions, and you'll be able to submit those to our nurse. I just want to focus here on questions related to the COVID virus. Let's see. People talking about their appointments. Are those with pulmonary arterial hypertension at greater risk? That sounds like a question for Enid.
Yes, they are. Pulmonary arterial hypertension is a very serious kind of vascular issue in a subset of patients with Marfan syndrome. I mean, we see a higher incidence of this, as Shaine could tell you, in our neonatal Marfan patients. The reason that it creates issues is that there's almost invariably associated changes and remodeling in the heart that's associated with the pulmonary hypertension. And so if that is a clear diagnosis and it's not related to a valvular process that will be addressed, or it's not related to another kind of reversible issue, then I would treat that as a high-risk diagnosis.
Just to echo, I totally agree. Pulmonary hypertension is a very severe diagnosis. It is slightly increased risk in our young patients with Marfan. Also in some, not in VEDS, Loeys-Dietz, or Marfan syndrome, but in ACTA2 and filament A, which are smooth muscle conditions that cause aortic dilation, so might be on the call or might be tuning in. They definitely have an increased risk of pulmonary arterial hypertension or pulmonary hypertension. And they tend to have much low reserve, be much more fragile, be much more susceptible. And specifically our filament A patients, they tend to have intrinsic lung disease, as Enid knows, and so would be very at risk.
Okay, and we still have a lot more questions here. We have a little bit more time. Are people with VEDS who have dissections of carotid arteries and iliac artery aneurysms at a higher risk and And I don't know, it's just what would they be? I don't know. I mean, we're talking about the risk for the COVID virus. So do those situations put people at higher risk if they have VEDS?
Do you want to answer that one? Or?
Yeah, well, I would say it's it's unknown in terms of any clinical information that's come from actual clinical experience, but I think from a position of common sense, I would say yes, these are people with fragile bodies and fragile blood vessels. So whatever happens to your body, if you're already coming from a position of weaker tissue, I can imagine that would be higher risk.
Okay. Shaine, here's a question about toddlers with Loeys-Dietz. If they have a low immune system, should they stay quarantined just to be safe?
Well, again, I think it can happen, but it would be uncommon for a child with Loeys-Dietz to be immunocompromised. Now, there is that subset that has eosinophilic esophagitis, or if they're on chronic steroids, but that's a very small proportion of patients with Loeys-Dietz. And so I think that would need to make a decision with their personal physician. I think for most people, they would not need to be quarantined without an exposure. But if they think they're particularly high risk or actually have an immunocompromised diagnosis, I would talk with their personal physician.
There's a lot of questions here. People talking about their specific situation, and they have VEDS, so they have Marfan, or they have Loeys-Dietz, and they have a lot of the different kind of risk factors that you're talking about. Maybe some of them are maybe they don't have all of them, maybe they have a few of them, and they're talking about they live in San Francisco or they live in New Rochelle, the area of New York that has been contained, and or they're flying, or they work in a hospital, and they're wanting to know if they should stay home, should they practice social distancing, are they being paranoid, are they reasonable? I think people are looking for some guidance about what is, maybe trusting themselves, maybe, and not overreacting, and how do you make these judgments? Because I couldn't possibly read you all these situations. Can somebody have any wise words of wisdom for people?
I think my general answer to that would be your local circumstances they're different in different communities, and that's we have announcements made by our local health officials. There's always your own personal doctor, but I also think that as we get more widespread testing, which will happen in the next week to several weeks, we will have a better idea. Right now, we're in a sort of lack of information situation in many communities because we haven't done that widespread testing. In our own community, we know we have a couple of cases, but we really don't know how many infected people we have in the community because we haven't done the testing. But ask me in 2 weeks and I'll have a better idea. But it seems reasonable during that period of time to just use these common sense measures, for a period of time until there's more information.
Agreed. I think social distancing is smart, now, and it gets to the extremes like quitting school. I think you have to really reconsider, but things about not shaking hands with people, not hugging people, that are close in your family, hand washing, trying to avoid unnecessary travel or non-mandatory travel. I think all of those are probably smart in the current culture for everybody.
Yeah. And
go ahead, sorry.
The only thing I would add is that if you don't fall into a high-risk group, what you need to monitor is whether you develop kind of cold and flu symptoms, because that's the point where you have the option of staying at home until you can fully resolve it or until you can be tested. That's when those particular choices and options come into play. If you are totally asymptomatic and have not been exposed to someone who has the virus, then you need to focus on those kind of external, kind of social contexts so that you don't get exposed or infected. And so that means kind of keeping your distance, not going into crowded situations, minimize your exposure to big public crowds, and practicing kind of the hygiene with the Purell and the wipes. And also, and this is very important for women, and I'm telling all my patients to pick out some type of a cologne or perfume and put it on their wrist, or use a soap where there's a distinct kind of perfume, so that whenever your hand is close to your face, you recognize the scent and you will move your hand away. And women constantly touch their hair, they touch their ears, they touch their faces. So we need prompts so that we don't do that. And I found that that's a pretty effective one.
One thing sorry. Huh?
That's good.
I know.
Go ahead, Shaine.
One thing specifically, this is echoing something Enid discussed earlier, but just really focusing on kids. Kids seem to be a lot less effective than adults with this, but we all have these nuclear families, and I think we really, really have to think kids are getting very much exposed and taking it back to our elderly adults, to grandparents, and to parents and aunts and uncles. And I think when we're talking about limited travel, it might also be your grandparents might live in the same city and you have every Sunday dinner, but to really think about those interactions for the next few weeks, do you really need to do that? Your kids who may seem totally asymptomatic, do you really need to be exposing your elderly family members to them?
That's a great point. I think even with holidays coming up in April, we should all be thinking about those big family gatherings and you like to have outside people come, but we should think about those.
It could just be masks and kids, and then the children. That's what we're most worried about in our community, is that our kids are giving it to more susceptible people.
You all mentioned, with testing, hopefully more widespread testing coming soon, testing being available. So should people with these conditions, with Marfan, VEDS, Loeys-Dietz, if they're having some cold, flu-like symptoms, should they really push to get the coronavirus test? Should they be really assertive about it? What if they're being brushed off a little bit? Should they really insist on getting it?
Knowledge is power, and as these tests, become, and it'll be very soon. In our case, the Mayo Clinic has just developed a test, which they say is going to be deployed in our community very quickly. I hope that works. But if testing is available, then sure. Now, here's a very important question that does come up, and is it possible to be tested too early? So for example, if I go have a test and it's negative, can I really believe that? What if I were retested in a few days? And I think the answer to that, maybe there's some definite knowledge, but the general knowledge would be that these viruses infect, your throat and your sinuses, and there's a period of viral kind of reproduction with no symptoms. But by the time that you do experience symptoms, you really are shedding a lot of virus particles. And in general, by the time people have symptoms, the tests will work. Do you think that's fair to say, Enid?
I fully agree, Juan. And I think the other consideration, and this will definitely become an issue once the tests are more available, is how do you establish that someone has fully cleared the virus? And in hospital settings, we typically test a person after several days before we take them out of quarantine or out of respiratory isolation. And so that may become kind of the practice for people who have an established infection, even if they're able to go back home. So you will see changes and what our approaches will be for people who are at risk, people who have infections, and people who have infections of different severity. But what I would recommend is on your, most of us have like the list of phone numbers on your refrigerator. You should have a COVID list of phone numbers of people of places that you will contact. And that includes your healthcare provider, your local health authority on the virus. And that could be in your city or in your state. You should also have kind of websites. And I would tell you to look at the CDC and the World Health Organization. They have the most current information. And please don't go to every possible COVID website because it'll drive you crazy. Just pick two that you can rely on and will have current information. And the last thing is to pick a media source, just one media source, because you will be flooded with lots and lots and lots of information, some of which will make you absolutely loony. And so you have to have a restricted set of sources that you can routinely go to and know that you're current with the information, because the knowledge and the understanding of this virus is changing it feels like on an hourly basis.
Wow. We could go on for like another 2 hours here with all these questions, but what we're going to do is we're going to take all the questions and make sure that we've answered, whatever we've not answered here, we will answer through our help center, and Jan will answer them, and she'll get back to our PIB members who are here and other ones that she might need help with, and we'll get your questions answered. Jan, and you can also submit additional questions to Jan. There's her picture right there. She's a nurse who works right in our office. And if you go to marfan.org/ask, that's truly the fastest way to get your questions answered. It's processed much faster than if you call her or if you email her. So please go to marfan.org/ask to submit any other additional questions. The Marfan Foundation is going to stay on top of this current issue, and we will continue posting updates and working with our professional advisory board. We put something out 2 days ago. We have a new statement out today. We will send a link to you tomorrow with this recording, as well as the link to today's update, as well as the link to the CDC guidelines and any other links that we think are going to be beneficial to you. We're going to include that slide that we did not get in here from Shaine today, and we will talk about that. The other thing I want you all to know, Michael mentioned that we're postponing some of our in-person events, but we're really ramping up our virtual events. And because we have all these capabilities like this webinar, we have a lot of new things in the works already. A new webinar series, we have online and phone support groups. In case you haven't seen it yet, we have a global virtual Walk for Victory. We have, I don't know, 30 or 40 teams already registered from around the world, including Betsy in Costa Rica, and we have Germany and Australia and everywhere in the U.S. and in Africa, I believe, as well. So that is also on our website. Go to marfan.org and click on Walk for Victory, and you can get involved with that. And just know that we're here for you. If you have more questions, if you have suggestions, and somebody is saying they'd love to do this again, I mean, certainly we will monitor the situation. And in a couple of weeks, there's a lot more questions. There are new developments on the coronavirus. We will have another webinar just on this. But we will be putting out information on our website, on our social media. Follow us there, and we're here for you. So with that, I really would like to thank Dr. Neptune, Dr. Morris, Dr. Bowen for their time tonight. This has been really incredible, so much information. Thank Michael Weimer for kicking us off, and for my partner in crime, Joe Grima, for putting this together with me and with everybody on this webinar. And thank you all for participating, and we will keep you posted. And please let us know what else we can do for you, because we are here for you. So thank you, and have a good night.
And remember to wash your hands.
And wash your hands.
Have a good night, everybody.
Right.